Thank you. On behalf of the International Society of Refractive Surgery of the American Academy of Ophthalmology, ISRS AAO, I am happy to welcome you to the presentation of the 2008 Barraquer Lecture Award and this year's Barraquer Lecture. Before I do, I'd like to provide a little background.
All of you, including especially the leadership of ISRS, for this extraordinary honor, and I'm humbled to accept this lectureship award. Before I start, I do want to make one comment. I have one first that John Marshall doesn't have. Along with Carmen Pulifido, I was the first author on the first submission to ARVO on excimer laser research into clothes. And the penetrating keratoplasty has had many triumphs in the past half-century. We've had the operating microscope introduced instead of loops. We've had the development of 10-0 nylon sutures and very fine and sharp needles. Then corneal topography, as we just heard. We've had increasing ability to manage immune rejection. And most recently, increasing sophistication in terms of understanding the importance of the ocular surface and how to control its role in corneal transplantation survival. But nevertheless, we have a number of unsolved optical problems. The recovery of vision is painfully slow for these poor patients. They have reduced best spectacle corrected acuity with what we used to call irregular astigmatism and now refer to as high order aberrations. And even when they have regular astigmatism, it is often very high, resulting in the use of spectacles that distort their vision or mandatory use of rigid contact lenses in a disproportionately high number of patients. So what we want to do is look at some new approaches to do better. And I'm going to just briefly acknowledge that there are many that I don't have time to touch on. Sonia Yu and Buddy Culbertson in particular who pioneered sutureless anterior lamellar keratoplasty using the femtosecond laser to try to get less distortion and better vision in these challenging cases of anterior lamellar keratoplasty. And of course, DLEC, DSEC, DSAG, and hopefully even DMEC, pioneered by Garrett Mellis, and then in the United States, led by Mark Terry, as well as many others. And these are very, very important aspects of corneal transplantation. But what I want to emphasize on is the work we've been doing on the femtosecond laser-enabled keratoplasty and really address this issue of why do we have to make transplantation surgery even more complicated. Now, this is a laser-based project, and it's been said from the beginning that lasers had no use in a few years earlier, published in archives, but very, very difficult again to get perfect shapes that would align, whereas the laser can do that quite readily. So this is the so-called top hat shape for that configuration. The inversion of the top hat, so-called mushroom, you can do a standard straight wall if you wish, but we started evolving other shapes, and this became known as the zigzag. I wanted to call it the Zorro, but Interlace thought that they'd be sued by MGM the next day, so this became zigzag. Okay, we just went backwards for unexplained reasons. Christmas is the inversion of the top hat, and then modification to zig square, and then been many others. The challenge is about that idea, because this looks just like the initial incision for a group. This is the preparation of a donor on an artificial anterior chamber. It goes very quickly, very hard to see, but I've done this for those who aren't used to what it looks like looking down through an interlace. So when I now show you the same thing on a patient where it's easier to see, you'll know what you're looking at. So you're looking down through the laser, you'll see the laser rotated, and in this case now we applanate. It's in the anterior chamber, so you see bubbling, and then it starts to cut into Descemet's membrane and advance at an angle in the posterior stroma up, in this case, to about 300 microns going toward the periphery. When it hits the preset limit, it'll then create a ring cut, which is we just saw there, and then advance toward the front, again, at a 30-degree angle, and then eventually breaks through on the front surface, and you see the bubbling. So that's how we cut the patient, and that's how we cut the donor in exactly the same way, so they're exactly the same shape. And this is what it looks like post-op. You can see there's very little suture tension required. There's only a minimal amount of bunching here, and you can see the reflection on the anterior 30 degree. We were greatly aided by anterior segment imaging with the Bizante OCT, and it showed us both the configuration, so we could evolve all these different shapes and pick one that really worked, and you can see how well aligned the posterior surface is there. But also, you can see going from 1 month to 3 month evidence of accelerated healing. You see the increased signal return from the zigzag there. And also you can see the imaging of one of the sutures coming down here. It's only half depth, and yet the posterior unsutured layer is remaining. Now, posterior part and expose the posterior depth, and then go in with a blade and scissors and cut around 360 degrees with the scissors, which 4 cardinal sutures, we do go to great lengths to try to get the suture to come out through the little apex of tissue, the little tongue, so that we can then insert that into the groove, and that gets the initial alignment set up. From that point onward, it's less critical with the intersection of the tissue. The tissue will largely naturally find its own plane. So you see they're looking for that little groove and the needle going in. And I want to point out this is actually suturing being done by a cornea fellow. This is not me. And so you see it's quite teachable and quite readily learned. So again, one more cardinal suture, you get the idea of searching for that little zigzag quite clearly. And less induced astigmatism under 3 diopters by the 3rd month, and better recovery of best spectacle corrected vision. Our latest results as of this summer, which we now have submitted for publication, we have now over 150 eyes that we've done, but we have 46 eyes and 40 patients that we could compare to a contemporaneous group of conventional penetrating keratoplasty with the Barraquer Award, 17 eyes and 14 patients. And what made them otherwise identical was the similar demographics, single 24 by running 10-row nylon closure, and at least one, but in most cases 6 to 12 months of follow-up with no difference in the demographics. And you can see the astigmatism curves, and this is held pretty consistently as we add more eyes, that we basically get about a diopter and a half difference on the average between the 2 groups. We're not perfect, we still have a few bad results, but most of them are on the lower end, as low as 22 or better. We had nearly half, 20-25 or better, with just spectacles, and even 15% 20-20, and statistically highly significant difference at month 1 and 3. More recently, we've been looking at aberrations as measured.
And if you'll allow me, I'll give you the Barraquer